Risperidone long-acting injection in schizophrenia management. Schizophrenia affects approximately 20 million people globally, who, 2023, with dopamine D2 receptor dysregulation playing a central role in its pathophysiology. Diagnosis requires greater than or equal to 2 of the following symptoms: delusions, present in 90% of cases, hallucinations, 70%, disorganized speech, 60%, grossly disorganized behavior, 50%, or negative symptoms, 80%, persisting for greater than or equal to 6 months per DSM-5 criteria. Risperidone long-acting injection, RLAI, is FDA-approved for schizophrenia maintenance treatment, administered intramuscularly at 25 to 50 milligrams every 2 weeks after an initial oral risperidone lead-in of 1 to 3 mg/day for 21 days. It reduces relapse risk by 60% compared to placebo over 1 year, NNT equals 5, with serum prolactin monitoring required due to a 35 to 40% incidence of hyperprolactinemia. Key points. Note: risperidone long-acting injection, RLAI, is dosed at 25 to 50 milligrams intramuscularly every 14 days, with a maximum recommended dose of 100 milligrams every 14 days. RLAI reduces annualized relapse rates from 64%, placebo, to 24% active treatment, yielding a number needed to treat, NNT, of 2.5 over 1 year. Prior to RLAI initiation, patients must receive oral risperidone 1 to 3 mg/day for 21 days to assess tolerability and prevent acute exacerbation. RLAI increases serum prolactin in 35 to 40% of patients, with levels often exceeding 3 to 5 times the upper limit of normal, ULN, 20 to 25 nanograms per milliliter in men, 25 to 30 nanograms per milliliter in women. QTc prolongation occurs in 1.2% of patients on RLAI at doses greater than 6 milligrams per day, with a mean increase of 6.8 milliseconds. Doses greater than 6 milligrams per day are associated with a 2.3-fold higher risk. RLAI is contraindicated in patients with dementia-related psychosis due to a 1.6, 1.7-fold increased risk of mortality, 95% CI, 1.2 to 2.3, based on pooled antipsychotic trials. The half-life of RLAI is approximately 3 weeks, with steady state achieved by week 4 to 5 of regular dosing. RLAI should be administered in the deltoid or gluteal muscle. Gluteal injection results in 20 to 30% higher bioavailability than deltoid. In elderly patients, greater than 65 years, starting doses should not exceed 12.5 milligrams every 2 weeks due to increased sensitivity and fall risk, RR equals 1.8. RLAI is pregnancy category C. Neonatal extrapyramidal symptoms occur in 12% of infants exposed in the 3rd trimester. For moderate hepatic impairment, child PUB, RLAI dose should not exceed 50 milligrams every 2 weeks. Severe impairment, child PUC, is a relative contraindication. RLAI improves medication adherence from 40%, oral antipsychotics, to 85% at 12 months, reducing hospitalization rates by 52%. Overview and epidemiology. Schizophrenia is a chronic, severe neuropsychiatric disorder characterized by disturbances in thought, perception, emotion, and behavior, defined by the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, DSM-5, and assigned ICD-10 code F20.9, schizophrenia, unspecified. The global prevalence of schizophrenia is estimated at 0.28%, 95% CI, 0.25 to 0.31, corresponding to approximately 20 million individuals affected worldwide, WHO, 2023. Regional variations exist. Prevalence is 0.32% in North America, 0.26% in Europe, 0.24% in Asia, and 0.3% in Latin America. Incidence rates range from 7.7 to 18.5 per 100,000 person years, with a median of 10.4 per 100,000 annually. The disorder typically manifests in late adolescence to early adulthood, with a median age of onset of 25 years in males, range 18 to 25, and 28 years in females, range 25 to 35. A bimodal distribution is observed, with a second peak in women between ages 45 and 50. Men are 1.4 times more likely to develop schizophrenia than women, RR equals 1.4, 95% CI, 1.2 to 1.6. Racial disparities are noted. African Americans have a 1.5-fold higher incidence compared to non-Hispanic whites, while Asian populations exhibit a 20% lower incidence. Urban birth is associated with a 2.1-fold increased risk, 95% CI, 1.7 to 2.6, and migration status confers a 2.7-fold higher risk in first-generation immigrants, especially from the Caribbean to the UK. Pathophysiology. The pathophysiology of schizophrenia involves complex interactions between genetic vulnerability, neurodevelopmental disruption, neurotransmitter dysregulation, and synaptic dysfunction. The dopamine hypothesis remains central. Hyperactivity of mesolimbic D2 receptor signaling underlies positive symptoms, e.g., hallucinations, delusions, while hypofunction of mesocortical D1 receptors contributes to negative, e.g., avolition, blunted affect, and cognitive symptoms, e.g., impaired working memory. Post-mortem and neuroimaging studies reveal structural brain abnormalities, including reduced gray matter volume in the prefrontal cortex, 12 to 15% reduction, hippocampus, 8 to 10% reduction, and thalamus, 7% reduction. Ventricular enlargement is present in 80% of patients, with lateral ventricles 30 to 40% larger than controls. Longitudinal MRI studies show progressive gray matter loss of 0.5% per year in the first 5 years of illness, exceeding normal aging by threefold. Clinical presentation. The clinical presentation of schizophrenia is heterogeneous but typically includes positive, negative, and cognitive symptoms. Positive symptoms occur in 90% of patients and include delusions, 90%, hallucinations, 70%, predominantly auditory, disorganized speech, 60%, and grossly disorganized or catatonic behavior, 50%. Delusions are most commonly persecutory, 65%, followed by referential, 45%, grandiose, 30%, and religious, 20%. Auditory hallucinations are experienced as voices commenting, 50%, conversing, 30%, or commanding, 25%, 15% report third-person hallucinations. Negative symptoms are present in 80% of patients and include blunted affect, 75%, alogia, 60%, avolition, 70%, anhedonia, 65%, and asociality, 70%. These often precede positive symptoms by 2 to 5 years and are more predictive of functional outcome than positive symptoms, R equals 0.58 versus R equals 0.32. Cognitive deficits affect 90% of patients and involve attention, impaired in 85%, working memory, 80%, processing speed, 75%, and executive function, 70%. The mean IQ in schizophrenia is 85, SD equals 12, 15 points below population average. Key points: suicidal ideation with plan/intent, lifetime prevalence, 50%, attempt rate, 25%. Command hallucinations to harm self/others, present in 12% of violent patients. Neuroleptic malignant syndrome, NMS fever greater than 38.5 degrees Celsius, rigidity, CK greater than 1000 U/L, autonomic instability. Severe catatonia with stupor or mutism, BFCRS greater than or equal to 10. Diagnosis. Diagnosis of schizophrenia follows DSM-5 criteria, requiring greater than or equal to 2 of the following symptoms for a significant portion of time during a 1-month period, with at least 1 being delusions, hallucinations, or disorganized speech. 1. Delusions, criterion A1, 2. Hallucinations, A2, 3. Disorganized speech, e.g., frequent derailment or incoherence, A3, 4. Grossly disorganized or catatonic behavior, A4, 5. Negative symptoms, A5. Additionally, there must be continuous signs of disturbance for at least 6 months, criterion B, with at least 1 month of active phase symptoms. Social/occupational dysfunction, criterion C, must be present for a significant portion of time since onset. Schizoaffective and mood disorders must be ruled out, criterion D, and substance/medical conditions excluded, criterion E. ICD-10 criteria are similar but require symptoms for 1 month and emphasize first-rank symptoms, e.g., thought insertion, broadcasting. Key points: complete blood count, CBC rule out anemia, infection, WBC 12E000/MUL suggests inflammation. Comprehensive metabolic panel, CMP no less than 135 millimoles per liter, SIAD, Ca superscript 2 less than 8.5 milligrams per deciliter, hypocalcemia, glucose greater than 126 milligrams per deciliter, diabetes. Thyroid stimulating hormone, TSH reference range 0.4 to 4.0 mO/L, hyperthyroidism mimics psychosis. Urine toxicology, detect amphetamines, cocaine, cannabis, false positives occur in 5%. References. 1. Alamo C. Risperidone ISM as a new option in the clinical management of schizophrenia, a narrative review. Advances in Therapy. 2022, 39, 114875-4891. PMID, 360484404, https://pubmed.ncbi.nlm.nih.gov/360484404. DOI 10.1007/S12325-022-02299-8. 2. De Philippis et al. The place of risperidone in situ microparticles, ESM, among long-acting injectable antipsychotics in schizophrenia treatment. Expert opinion on pharmacotherapy. 2025, 26, 1379-1397. PMID 408547888, https://pubmed.ncbi.nlm.nih.gov/408547888. DOI 10.1080/14656566.2025.2551636. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.